Okay, perfect. We'll make a start on part 2. So I was asked to put together this lecture on 3 topics, and it's a huge amount for us to kind of cover very quickly. So TPLO, post-op aftercare, but TPLO, and osteoarthritis. So maybe quickly by a show of hands, who's more interested in osteoarthritis? Who's more interested in post-op care? And who's more interested in TPLO? And who doesn't really like orthopedics and came for feline neurology? Okay, so that's good because I'm a bit more towards the front and we'll get a bit quieter as we go along in terms of the amount of slides that we got. So that kind of matches with hands, but we'll try and get through all of them if we can do. So it's being recorded. So for anybody who is watching this on catch up, this is me if you've not yet met me. So I'm James. I'm one of the orthopedic specialists and also a specialist in canine sports medicine. So I'll be the voice that you'll be hearing if you're watching this online. So I guess when you probably told your friends you're coming to the theatre this evening, they probably weren't thinking the lecture theatre. They were maybe thinking this kind of theatre, but as vet professionals, we're a bit different to everybody else. And we come along to CPD evenings and the RCVS make us as well. So rather than this theatre, I didn't want to show you this. I wanted to take you to a different theatre. I kind of wanted to take you guys downstairs into surgery, but it's quite comfy up here. So we'll stay up here and I'll show you some photos and videos. So we're going to talk about TPLO. So, you know, very, very kind of basics. I suppose, as you know, the TPLO is a surgery for the stifle and a surgery for dogs who have ruptured their cranial cruciate ligament. So what I'll kind of do is I'll kind of run through a little bit how I talk to clients during the consult and kind of explain it to them, because sometimes it can be that we know what we're going to be talking about, but clients sometimes are on a very different wavelength to us. So it's very good, I think, if we can sort of break things down into sort of simpler terms, and almost kind of using, I think it's like Einstein's quote that if you can't explain something to a 5-year-old, you don't really kind of understand it. So it's quite good to kind of break things down, simplify it. And also cruciate disease or ACL ruptures are really common in people. So quite often a lot of clients will have either done it themselves, or maybe we'll know a friend who's done it, or we'll seen lots of athletes on the media having ruptured their ACL. So they maybe already have a bit of a notion as to what's involved, but it's quite different in the dog to the human. So I quite often try to explain the differences to them as well. So I usually kind of start with this little video that we have, and you can grab this from our website if you wanted to use it as well. And basically tend to sort of explain to them that we have the 2 ligaments that form a cross inside the stifle joint, the cranial and the caudal. In humans, if we rupture our ACL, it's usually a trauma. So it's maybe an athlete getting tackled or somebody skiing, twisting their knee. Whereas in dogs, most of the time, it tends to be a degenerative sort of disease process where the ligament starts to fray, break down slowly, and then can give way without any major trauma happening. So the classical narrative is a dog's maybe been not quite right, a bit stiff for a few weeks, and then suddenly starts to become more lame. And we have the tibia and femur sliding past each other in this abnormal movement, stretching all of the tissues in the joint, making it uncomfortable. And also the dog can maybe feel like their knee is going to give way, so they can lose confidence in using it, so we'll start to limp and use it less. So in terms of kind of how we diagnose this, we can diagnose it based on our examination. So the classic ones will be the kind of cranial tibial thrusts and also cranial draw. So with cranial tibial thrusts, we're trying to mimic the patient loading the limb and walking. So effectively what I'm doing is holding the femur in a fixed position, applying force to the foot as if we're loading the leg, and we'll then see that tibial tuberosity thrusting forward. And we can also do our cranial draw, as I'm sure you're all aware, where we'll kind of grab the femur and the tibia and move them past each other. And in dogs with a complete rupture and it's very unstable, like in this one, you'll see a huge movement. In those who've just got a partial tear, they'll be much, much more subtle and sometimes harder to feel when the dog is conscious and easier to feel when they're sedated or anesthetized. And another little trick, I suppose, if they do have a partial tear, quite often if you put the stifle into flexion and then do your thrust or your draw, you might get a little bit of movement then if just part of the cruciate ligament is torn and part of it's still intact. So that's another little tip. So typically once we've kind of done our examination, we will then take some radiographs, and they're the kind of classical hallmarks on radiographs for a dog with a ruptured cruciate. So these are both examples. So what we'll see is the fat pad being pushed cranially and the increased effusion. So this lighter gray is the effusion and this darker gray is the fat pad, and this pushes this forward. It's a bit harder to see maybe, but also at the back of the joint, we'll have effusion back here with this lighter gray, and this little fascial plane will get pushed caudally from the effusion at the back of the joint. And then something you can see quite clearly between these two is on the image on the right, you'll see how the tibia is shifted cranially relative to the femur. If we use this as an example, we can see how the center of the plateau is lined up with almost the center of the condyle. And then on here, there's a big displacement. So that's another kind of key feature. You won't see this on every radiograph, but if there is a complete rupture and it happens to kind of move that way when the radiograph is taken, then you can spot that. So when I kind of talk to clients, I'll kind of describe to them that we can take radiographs and we're looking for these signs to show there's something causing degeneration in the joint, and we're kind of ruling out there aren't any other problems. And we can also use our radiographs to template and plan for surgery. And what clients might ask is, well, why don't you do an MRI? Because if I was a human, I would have an MRI done. And we can do MRIs of stifles, but usually it's not needed because usually we can feel an instability and see the classical signs on the radiographs, but we can do it in certain cases. In terms of, I guess, why we don't do it so often, one is because of the costs. Second, it takes quite a long time to run an MRI. And the third thing is sometimes it can be a bit frustrating because anatomy is not being made perfectly for sort of MRI scanners, in so much as we tend to line up the stifle in the MRI scanner, have it all perfectly straight, and the MRI takes a series of slices through the knee. But the way the cruciate ligaments are in the dog is they do come at an angle, and therefore you never get them perfectly in line unless you try to manipulate your MRI image, which then means trying to take it again at different views and different angles just for the cruciate ligament. So frustratingly, the caudal one usually looks very nice, and the cranial one, you often just get to see part of it, and then you have to scroll through to the next slice to see a bit more. And then in this example, we can't see the cranial anymore. It's been disrupted. And again, we have a little bit of effusion in that stifle as well. So we can do MRI, but most of the time we tend not to need to do it. So at this stage, we can maybe feel a draw. We can see on an MRI, if we did do that, we can see our changes on the radiograph. The next step then, if we are going to go to surgery, is just to kind of completely confirm the diagnosis. So we want to actually look inside the joint. We can either do that with an arthrotomy, or we can do it arthroscopically and get kind of a nice magnified view and see the changes. So you'll see this is the caudal cruciate that's intact. And then we've got one end of the cranial cruciate and the other end is just here. And this kind of shaver is not actually cutting, but it's just suctioning the two ends. So you can see them within the screen there, just to get the video. And so we've then kind of confirmed our diagnosis. And then what we know is if dogs have a ruptured cruciate ligament, and particularly if the stifle is quite unstable, they are at risk of having a meniscal tear as well. And it's usually the medial meniscus is the one that has a problem, and it's usually the caudal horn of the medial meniscus. So it's kind of really important to check that as well, particularly if it's very unstable, and particularly if it's perhaps been a chronic problem as well. So we do know that dogs who have had a unstable stifle for longer are also more likely to have a meniscal tear. So again, we can either just do that via arthrotomy, or we can do it arthroscopically, and therefore we can get a magnified view. And not only do we look, but we'll also probe and manipulate the meniscus to see, are there any tears that our probe can drop into, and see how much movement, if there is any displacement. So this meniscus was all okay. So we can give it a good probe. And in this meniscus, there is a tear. So the probe's actually dropped inside of the tear. It's kind of what we call a bucket handle tear. So you might have come across that phrase perhaps, or seen it in reports. Basically what it means is there's a tear running through the meniscus that creates a little gap. So when we put the probe in and pull, it's almost like having a handle of a bucket. So it's actually like having a bucket and a bucket handle. It's not anything fancy other than that's what it looks like. That's a phrase you might see quite often, is a bucket handle tear. And I suppose on the subject of arthroscopy, what we do now have, which is very nice, is now a needle arthroscopy. So this is an even smaller scope. It's just the size of a slightly bigger needle. So we can use this to do arthroscopy in very, very small dogs. So we can also use this for lots of other cases in dogs where maybe we want to do diagnostic arthroscopy. So we want to look inside a joint. but not put the patient through kind of a big procedure. So we can just do potentially a little small clip, put a drape over, some sterile gloves, and just like you would do arthrocentesis and put in a needle, you can actually put in the camera and look inside. So this is a dog that's had a shoulder arthroscopy to look around inside to check its shoulder. Also then via the needle scope can administer medications as well. So we then administered some PRP, and you just end up with this little tiny hole. You just put a bit of skin glue to seal it. So we can do that as well, often under sedation if we've got sufficient analgesia on board. So we can do it almost on a a very quick outpatient basis. So that's something that we can offer as well. And it's also really good if we do have a late meniscal injury, so a dog that's already had surgery, like a TPLO, and then they end up having a meniscal tear. The chances are quite low. It's only kind of a few percent if the meniscus has been assessed during the initial surgery. But if that does happen, it can be a bit difficult to diagnose because you don't see the meniscus on radiographs or CT very well. And if you try to do an MRI, you've got a metal plate that just distorts all of the image. So being able to put in the scope with a minimally invasive approach is quite nice to be able to do that. So in terms of treatments, basically, yeah, lots of people will have maybe either had an ACL repair themselves, or they're aware of somebody or an athlete who has had an ACL repair. And clients might be thinking that something similar is going to happen to their dog. So I kind of described to them that in humans, you would have a repair or an augmentation to your ACL. And we can do the same procedure in dogs, but what we've tended to find is that there is quite a high failure rate with that ligament sort of re-tears. And part of that can be because there is a degenerative process going on in the joint. So it will cause any new ligament you put in, if it's a donor ligament, to degenerate. And also the differences between us and dogs is we will hopefully listen to our surgeon, not go back to playing sport for months, whereas dogs are going to try and run and jump the day after surgery. Dogs are a lot smaller than us. Their knees are a lot smaller than ours. So it's a much smaller ligament that goes in, but they generate more power in their muscles than we do. So there's more force on a small ligament. And then I start to go on and tell them, and the big difference between us and dogs is the shape of the knee. So the image on the left is a canine stifle, and the image on the right is a human stifle. And in the human stifle, the tibial plateau is generally very flat. And I kind of describe it as being like a flat tabletop with the femur sat on top. So it's actually quite a stable surface in the way that gravity loads this. And if you're a human and you're not an athlete and you rupture your ACL, you can get away without needing to have any surgery done. The rest of your muscles just hold everything in place and it balances in position. Whereas in dogs, they have this steep slope. I'll then show them the video again of the subluxation of the femur sliding past the tibia. And therefore, any artificial ligament we put in has to hold the femur at the top of the slope. It's got all of the dog's body weight coming down onto it as well. So there's a lot of force on a ligament that we put in. So I then tell people what we're going to do is this is kind of an oversimplification, but what we're going to do is make the dog knee more like the human knee and change the shape of the top angle, the plateau. And then the way in which we can do that is if we have these, say, bones sliding past each other, the femur sliding down the tibial plateau. Then what we can do is make a semicircular cut in the bone, rotate this portion around, then end up with a flat surface for the femur to sit on, use a plate and screws to hold the tibia back in position, and then everything will heal and fuse in that way. And we've kind of then gone more like the shape of the human knee. And then in most dogs, they actually don't then need to have a ligament replaced or repaired. We can just do the TPLO. There are some situations when we might do that, and I'll come on to that in a little moment. But for most of the time, we can then do the TPLO. So yeah, mentioned the word TPLO quite a lot. If we do have a dog with a ruptured cranial cruciate ligament, for generally all of us here at the practice, this is a procedure that we would probably do 99% of the time. We do have the kit downstairs to do other procedures. So a TTA, cranial closing wedge, a ligament replication with the tightrope in this case. These are all my x-rays. So these are all procedures that we've done, can do. But generally TPLO is the one that we kind of get the best results with. And also there is some studies also kind of indicating that studies are always really hard to do because it's hard to take the exact same surgeon, make them do one surgery on the exact same dog and another surgery on the other dog, and then kind of compare the results. So whenever there's studies trying to compare the two, it's usually different groups of surgeons doing different sort of surgeries. So it's always quite hard to get studies to kind of prove is one better than the other. but most surgeons will find that they're getting better results with the TPLO compared to the TTA and sort of ligament replacement or replication procedures. And there's probably actually more papers published on complication of TTA rather than sort of how the outcome is and the success and the positives. So how do we then do a TPLO? Do we just pick up the saw blade and cut the bone, or do we have to kind of think about it and plan it? So in terms of planning, we do this based on radiographs. So we will need to have a radiograph that is an exact medial lateral, and also to have all of the tibia in the radiograph. So if you take some radiographs at your practice in primary care, and then the dog ends up coming to us and we kind of repeat radiographs, the reason why is frequently because we need to have them in this exact position in order to take measurements from. So what we want is the condyles to be sort of superimposed over each other, and then also the sort of the talus to be superimposed over each other. So this one's not completely perfect, but it's pretty good. It will be absolutely fine for what we need. And there's kind of a saying that you're only as good as your last surgery or the last thing that you do. So this is the last surgery that I did on Friday before I wrote this presentation. So we'll use that one as an example. So we take this radiograph, and then what we do is we are able to have the software to then plan the TPLO. The other key thing that we need is something that allows us to calibrate. So you'll notice maybe on lots of our radiographs, there's this circular ball. The reason there's this metal circle ball is the computer knows how big that is, and therefore it picks that up when it takes the radiograph to calibrate everything for us. So these little measurements on here, we can kind of ignore. This is just so we know it's the right side, but that's why we have this little ball. So once you've then calibrated everything, we draw a line from the center of the talus up to the center of the plateau, and then draw a line that is running along the surface of the plateau and create the angle, and that gives us our TPA or tibial plateau angle. So for this dog, it was 30 degrees. And then what we do is we're going to plan where our cut's going to be. So we have this circle that would show where the blade would cut. And we want this to be aligned between the front of the joint, because we don't want to cut into the actual joint. And we also don't want to be too close to the tibial tuberosity. So we want to be somewhere in between. We also then want to make sure we've got enough room to fit our plate and screws on. And there's some other sort of subtleties that we'll want to be wary of as well. So we can then have our plan. Then what we want to do is once we've got our plan on the computer, it's no good at being on the computer unless we can replicate it in surgery in the dog. So what we'll do is take some measurements from the radiograph that we can then replicate in surgery. So one of the easy structures anatomy to find is the tibial tuberosity. So we can take a measurement from there back to where the cut will be. And then also what I will do is I'll use effectively the diameter of the blade from this top surface running down. There's a few other measurements that you can take as well. So maybe when we're sort of teaching, training residents, we'll get them to take some other measurements so they can kind of double check and cross check. But normally if I've got these two measurements, I'm happy with that. Then what we can also do on the software is we can actually start to do the surgery. So we can actually rotate the tibial plateau around and actually sort of prepare our cut. And then from that, we can then template on our implants to see how they would fit and look at different sizes and perhaps see where exactly on the bone they should go. So once we've got those measurements, we can then go to surgery. So once we're in surgery, we've initially looked in the joint first of all, either with an arthrotomy or arthroscopy, and then we can replicate those points. So we can use a needle in the joint and then measure our distance down, and then we can make a little mark at the back. Putting a needle in the joint is quite a useful little thing to do. If you are doing surgery and you're next to a joint, you can use a little needle to walk off the bone and just drop into the joint, and then you know where that joint surface is. So you know you wouldn't want to put any implants in above that line because you're then likely to be in the joint. We can find the tibial tuberosity, measure a distance back and make another little mark, and then we can join those marks up with a little semicircular cuts. We can just use the monopolar cautery just to scar the periosteum so we can see where our semicircle will be. And that's it's scarred, and then we can see that's going to then line up with our TPLO saw, so that's where we're going to make our cut. So then when we're in surgery, we can take our saw and we can then cut through the tibia. And as we're sawing through, whenever you do surgery, I suppose you're always thinking what can go wrong. Probably one of the most catastrophic things could be you cut through the patella tendon because it's an extremely important structure. We've just got these little gelpies in place. So that's going to hold the patella tendon out the way as the saw goes through. So then we've cut the bone in half. Then what we're going to do is make some little marks. So we'll have some marks that we'll make these just before we finish the cut, but we'll have a couple of marks, which I'll show you in a second. So I'll put these 2 pins in and then put this elevator in between and can use this to pivot to do our rotation. So we have one mark that's on the top part of the cut, one mark that's on the bottom part of the cut, and we can pre-create that distance from knowing what the plateau angle is before surgery, what the plateau angle is after surgery, and what the radius of the blade is. And we know if we then line up those 2 marks, then we know the plateau is now at the correct angle. So when you're in school learning trigonometry, wondering why am I learning this? So you could do a TPLO once you become a vet, basically. So yeah, the sort of steps of the TPLO is we make our semicircular cuts with a saw in the bone. We then insert our plate, and we can then put screws in the top of the plate, screws in the bottom of the plate, and then that is our plate in position. We'll sometimes leave this little pin in place just for extra stability, and it just means that the tibial tuberosity won't then fracture away. So we'll sometimes leave that in. So once we've done our surgery, we then go straight to radiography and check to see, are we happy? So have we achieved what we wanted to achieve? Is there anything that we need to go back into surgery and adjust? If we're not happy straight away, let's go and do it now before we recover the dog. Or sometimes less so with TPLO, but for some surgeries, we might think, is there anything that we might need to change in the future? So it might be that we say, well, we might adjust an implant or take something out in 6 weeks or 12 weeks once the bone is healed or once some healing is happening. So if we look at what we were aiming for, if you recall the distance that we measured pre-surgery, it was around about 12 millimeters. So we're pretty close there. And we're usually aiming for a plateau angle of about 5 degrees, which we've achieved through there. So we can be quite happy with that. Now, most of the time, for most dogs, just a TPLO will be sufficient to give us a good outcome. And 9 times out of 10, we have a very good outcome where dogs generally get back to doing what they were doing before. This is what I kind of tell clients. But technically, the knee's never completely normal. So they might not go to the Olympics and win the gold medal. And this is where clients usually laugh and smile a little bit. And I say, but for your pet dog that's back to running in the park in the field, they should be able to get back to doing that. But for some dogs, they are more complex than just a standard cruciate rupture. And therefore, we may kind of want to do additional things during the procedure. So for dogs who are extremely unstable, so maybe they're an acute tear, or they perhaps have not got much periarticular fibrosis or stability around them, and these are usually dogs that are kind of very lame, really unstable. But when we do the TPLO, everything that we've kind of shown so far with the videos and what we've explained shows everything moving in kind of 2 dimensions. It's just in that sagittal plane, but the knee is in 3 dimensions. It can rotate around. And we often just solely think about the cranial cruciate ligament preventing the tibia from moving cranially, but it also has multiple other roles. One of those roles is it prevents hyperextension. So in humans, if we rupture our ACL, it's usually a hyperextension injury to our knee that causes it to tear. And if you have a dog that has a cruciate rupture and you try to extend their stifle fully and really kind of lock it out all the way, they usually find that painful because you're putting a lot of stretch on the cranial cruciate ligament if there's some fibers remaining. And then the other thing that it does is it stops the knee or the tibia from internally rotating. So what we sometimes find if dogs are really unstable, their knee might rotate inwards more. And as it internally rotates, it can then thrust again. So this is something that is becoming, I suppose, a bit more talked about, a bit more aware of, but we can find dogs whereby we hold everything in a neutral position and we do the cranial tibial thrust test and everything is stable. And then we internally rotate a bit and we actually then get some instability. And if you were paying really super close attention to the video that I showed earlier on, which is this one, get it to play again, is you'll see it's moving thrust, and then I'll just rotate the hock just then, and then it's actually stable again, internally rotate, and then it's unstable again. So in this situation, if we have a dog that has a very unstable knee, we might actually want to put in effectively a ligament to replicate the original ACL. So we can do that at the same time as a TPLO. So this is kind of, I suppose, quite an elegant way of doing it, whereby this artificial ligament actually attaches onto a little part of the plate, loops around, and then goes into the bone via this swivel lock. So this is an interference screw. So these are effectively from the kind of human side that have then been able for us to use in dogs. So we can actually replicate that cruciate ligament as well. So if there's had a dog that's had this done, you generally won't see that on the radiograph. So these implants are all of kind of a plastic sort of material, so you won't actually see them. You'll just maybe see the faint drill tunnel in the femur where that implant has gone in. And there's other variations you can do. But these are things that we're all kind of assessing for. We're not thinking it's just a standard cruciate and we'll just do the TPLO. We're always thinking what's going to be the best thing for that individual dog and that individual patient. And also we can have comorbidities where some dogs don't only have an ACL rupture, but they might also have a patellar luxation. And in part, because of that increased internal rotation of the tibia, you might have a dog who didn't really have a luxating patella before, but now does, because the tibia is rotating inwards, moving the tibial tuberosity inwards, which is then pulling the patella inwards as well. So if you've had a dog, you've known that dog for a long time, it's never had a problem with the patella luxation before, and suddenly it's 6 years of age and comes in and has a patella luxation. Patella luxation is usually caused by alignment issues, and the dog's alignment will be set from once it's kind of skeletally mature, kind of a year of age. If it suddenly develops patella luxation later in life, maybe be thinking, has it actually torn its cruciate ligament? So we can actually resolve both problems during the same surgery. So for example, in this procedure, we actually modified the TPLO. So we've done the rotation to level the plateau, but also then slided the diaphysis that has the tuberosity attached to it laterally, which is then going to move the tibial tuberosity laterally to help realign the patella. We've then sort of recontoured and bent the plate in order to achieve that. And then in this particular example, we've done a tibial tuberosity transposition. So done a cut here and transposed that and then re-secured that with a pin and tension band all at the same time as the TPLO, and also done a sulcoplasty as well. And we would have done an imbrication to the lateral retinaculum. So we can basically, tailor and modify that procedure to what that dog needs. So we'll be assessing them as an individual. So that's kind of how we do a TPLO. Then we need to think about what happens when they go home. So we send them all home with a set of discharge instructions. It'll kind of look something like this, kind of broken down into different sections. And we try to kind of keep it as simple as we can. We're still giving them as much information as possible. If you give them a huge kind of booklet, they'll never look at it. Whereas if everything is on one page of A4, hopefully clients will kind of read through that and look through it. And when they come to collect their dog, we kind of go through it step by step with them. And actually prior to surgery, we've kind of gone through this step by step with them as well. So in terms of exercise, we do want to get dogs to be active and moving. So we kind of don't want them to just sit in a crate for months and months. We kind of want to get them walking, using their legs straight away the day after surgery. So generally with TPLO, we can get a nice, solid, stable construct with a large plate and screws. So the chances of something breaking is going to be generally very low, very small. So we want to try and get patients to be active. We do still need them to be confined because we don't want to put too much force onto the implants. So kind of what we want is for them to be rested in the house and out on lead walks. Now, in terms of this dog in this crate is far too small for this dog. We do want them to be comfortable and to have room. So for this dog, more like the size of the room would be appropriate. And I tend to talk to clients in measurements of rooms in terms of we're sat in the consult room. And I tend to say that if it's a bigger dog, like a Labrador or larger, I say a room the size of this consult room would be fine for them to be in. So if you have a room in your house that's that sort of size, that would be great. If they're maybe more of a spaniel size, or maybe say it's half the consulting room. And then for something smaller, I would say a crate or a pen. But if they do happen to have a open plan layout, then yes, for any size of dog, it might mean creating a penned off area. But we just want to avoid them. jumping on and off the furniture or running up and down flights of stairs. So sometimes it might mean a few modifications in the house, but they don't need to be in a small little tiny crate. And then out for walks on a lead, just kind of nice and slow and controlled, just so they're not kind of running and jumping. And the way in which implants fail is either by too big of a force, so one big huge force, which is why we don't want them to be kind of jumping on and off things or playing with other dogs, or they fail by something called cyclic loading, which is lots of small forces on the metal all the time. If you think about taking a teaspoon and just bending it back and forth little by little, eventually the metal will fatigue and it will break. So that's why we don't want them doing too much walking. So we'll start off short, 5 minutes or so for the first week. And that could be 2, 3, 4 times a day, so they're not getting too bored. And then generally, as each week goes by, adding on an extra 5 minutes. So by the time we're maybe at, say, 6 weeks post-surgery, when we'll often see them back for a follow-up, they may be doing a 30-minute or so walk a few times a day. And we will send them home with obviously some analgesia, and obviously don't want them to lick their skin incision. We will tell them a little bit about general health. So again, they're going to toilet is going to be a bit out of sorts sometimes after having various medications and fluids. So just kind of prep them for that. And then in terms of kind of reassessment and checkup, so standardly there would be kind of 2 checkups. The first one is usually just to check the skin incision is healed before kind of collars and everything come off. So it's usually about kind of 10 to 14 days after surgery. And then we'll often see them back around about 6 weeks, sometimes 8 weeks after surgery for a follow-up exam and potentially take some follow-up radiographs. And we will generally recommend and encourage rehabilitation that can start effectively straight away. So in terms of rehab, we will have our physios assess the dogs immediately the morning after surgery and put together an exercise plan for the client. And when the client comes in, we can then give them that plan. They can meet with the physio. The physio can show them how to start doing some exercises. And then they're obviously welcome to come back for outpatient physiotherapy or hydrotherapy or somewhere closer to home. So in terms of rehab, this paper is really good because it kind of breaks down, I suppose, the fundamentals of rehab. So we want to base our rehab on the degree of tissue healing, the strength of the patient, and kind of whatever the functional goals are. So basically, it means it needs to be specific to that patient rather than too generic. And the kind of key things are pain management. That's obviously the most important thing. And then doing therapeutic exercise and manual therapy to kind of return them to activity. So that's generally what most of our rehab team will focus on. It's more kind of exercises for the physio to show the clients how to do, and the physios doing the exercises and manual therapy with the dogs. And that's generally been shown to be more beneficial or has more evidence to back it up compared to some of the other modalities and toys that we may try to use in rehab. So a really nice thing in this paper is this chart. So what this does is show roughly how long all different tissues take to heal. And in terms of a TPLO in this chart, probably the kind of key ones are an intra-articular ligament. So that's our cruciate ligament. And that's generally unlikely to ever heal. So we know if they tear their cruciate ligament, it's generally not going to heal. So sometimes the analogy of, oh, maybe have a bit of rest and see if it heals. The ligament won't heal, it won't regenerate, it kind of won't recover. What the body will try and do maybe is form some scarring around the joint. You start to get these thickened knees. You'll start to get some what's called medial buttress, which is that thickening on the inner side of the proximal tibia. But that thickening just affects the whole knee. So you'll start to get a reduction in range of movement. And as that scar tissue is starting to slowly form, they might seem like they're doing a bit better as the dog rests, and then the doorbell rings, the dog jumps up, puts weight on its leg, it sort of stretches, and you sometimes go back to square one. So trying to manage them conservatively, you often kind of end up in these cycles where sometimes you feel like you're getting somewhere and then you seem to kind of take a step back. So generally would tend to be more proactive with surgery because we can get a very good outcome with that. And I would tend to intervene sooner rather than later, as long as you were completely confident with your diagnosis, because you're then less likely to get a meniscal injury and preserve the meniscus. And it's been shown that dogs who do have a meniscal tear develop more osteoarthritis later in life. So this is also a study done that looked at different types of publications that were assessing rehab after cranial cruciate ligament disease. And generally, what they kind of found is with most veterinary studies is if you look at the quality of the research, it's usually not that great because it's very hard to do really good quality research in kind of clinical patients. But some of the studies that are out seem to suggest that doing therapeutic exercise, so that's kind of what we might call physiotherapy in terms of exercises to improve strength, mobility, flexibility is beneficial. And there's also more evidence to suggest kind of cold compression immediately after the procedure. So in terms of our rehab, again, this is going to be based on the individual dog. And I suppose what's kind of important is to try to assess that dog and work out what does that dog need at that stage in its recovery. But in the first few days, so the day of surgery, that evening, and then the morning afterwards, and also perhaps when the clients first go home, we can start off with some cooling, some cryotherapy. That's going to try to reduce inflammation, reduce pain. We can do some gentle, slow, passive range of motion exercises, and perhaps also some gentle massage as well, just trying to get some of the fluid, the edema moving. And then we can also start to think about weight shifting exercises and some supported walking in some patients. So in terms of cryotherapy, we do have this kind of more fancier unit, kind of a game ready, which applies cool, cold water and also sort of applies compression to sort of squeeze the joint, and it can release that compression and increase it to get things moving. But you can just do it really, really simple with a cold pack in a towel that you've taken out of the freezer and apply that to the dog as well. And then we can do some sort of just, passive range of movement. So by passive, it means the dog's not voluntarily doing it. We are doing the movement. So the dog is being passive. And we're just putting joints through a range of movement just to try to help get the joints kind of moving so things aren't tightening down, helping to get fluid and edema moving and getting the dogs a bit more confident that their legs can move again. And this is what we'll often be showing clients how to do as well at home, which they can start straight away, but we'll let them know that, the first few days after surgery, the dog might not want them doing too much with their leg, but something they can then begin doing. Supported walking. So for most dogs, after a kind of, TPLO surgery, this wouldn't be needed, but this dog has had bilateral simultaneous single session TPLO. So first day after surgery, we're going to give them a little helping hand with a little sling underneath so that we can take some of their weight. And if they are a bit weak on their legs, we can just help sort of catch them as well. And also in that kind of immediate post-surgery phase, we will have used a nerve block or an epidural, so their nerve function to their limbs is going to be a little bit affected for that first sort of 12, 24 hours. Weight shifting exercises. So this is essentially getting the dog to make sure their foot is correctly placed on the floor, and then just ever so gently, just sort of shifting their weight onto that leg, just so they start to get confident, yes, they can load it. Proprioception starts to get kind of reloaded. So we can start to do this as very, very gentle, that we can start straight away. So after the first few days, the exercise plan is going to be, again, these kind of slow walks. And if they are interested in doing more physiotherapy, we'll be giving them exercises to continue to improve the range of movement, just so everything doesn't tighten down. Maybe then do some isometric weight bearing. So isometric is where effectively your muscles are not causing your leg to move. So it's basically standing still on that leg, rather than exercises that will cause the leg to move. So again, that'll be things like weight shifting. And we can also think about trying to reduce problems in other muscles as well. So in terms of what a dog should look like kind of, 2 weeks after surgery, if you look on the internet, everybody's going to post these videos where the dog looks amazing, is walking really, really well. It's just 2 weeks after a left TPLO and bilateral elbow scope at the same time, and it's, walking along pretty good. But generally after a TPLO, if dogs come to see you for a checkup 2 weeks after surgery, they generally should be using their leg pretty well and looking pretty good, but there will be some variations. So in terms of a time when a dog might not be looking so good, might be if that dog was really, really lame beforehand. So if that dog was almost kind of non-weight bearing before surgery, it's going to take them a bit longer to get confident at using their leg again. Part of that reason might be because it was extremely unstable, and therefore there might still be some instability if the dog has just had a TPLO. If we've done kind of like an internal brace, that might help with that initial stability. And also if a dog has had kind of a modified TPLO or TPLO plus something else, so if it was a TPLO combined with a dressing, a patellar luxation, usually those dogs will be a bit slower in their recovery as well. So we're usually saying dogs should be starting to, use their leg within the first few days of surgery. But if you've done a bit of a combination and a patella luxation correction, it might take them 3, 5, maybe even a week before they're starting to use their leg a little bit. So if you saw the dog before it was referred and you knew how lame it was, or it was in your notes, you can kind of predict how well the dog should be doing post-surgery. Then kind of moving through weeks kind of 2 to 4, we'll then be doing exercises that try to encourage more weight bearing on the leg, improving proprioception. So the dog might have to kind of almost relearn how to feel its leg, use its leg, place it correctly, and also then looking to improve the lameness and improving the way that the dog is walking. So some exercises that we can do might be to start to increase loading of the leg. So a way that we can do that in terms of an isometric exercise might be if we lift the dog's front leg, it's going to put more weight onto its back leg. And as you progress, you could put the dog's front legs onto a higher step and then lift the front leg. So there's then more weight on the back legs because the dog's front legs are slightly raised. And as you progress, if the dog has had a surgery, say on its left pelvic limb, you could lift its right pelvic limb and that will load that limb more. So that's ways which you could gradually increase the forces that are being loaded. A way to improve gait and also improve range of movement and also improve proprioception is exercises like Cavaletti poles. So these are a series of beams along the floor, and you can lift these up higher as the dogs progress. But what the dog has to do is be a bit more conscious of where its legs are so it doesn't trip over the poles. It's also going to encourage it to pick its feet up more. So you're going to increase the amount of flexion in the joints rather than the dog keeping its legs still and trying to keep its foot really close to the floor. So we'll be improving our range of movement and also improving our muscle strength and improving the way the dog walks rather than sort of shuffling with straight legs, get it picking its legs up. And then hydrotherapy. So in terms of hydrotherapy, I'm generally kind of happy for dogs to start almost as soon as possible. The thing that's going to kind of hold them back is the one thing that we really want to avoid with orthopedics is an infection. So we do want to make sure our skin incision is fully healed. So we might say, well, it's going to be around about 2 weeks' time and then it should be kind of fully sealed. But what I tend to recommend to people is just have an extra week's leeway, and I tend to suggest 3 weeks. And the reason for that is, you will have seen a dog and taken some stitches out after 2 weeks, and the skin might still look a bit red, particularly if the dog has nudged it with its collar, or the stitches may be a bit sort of tight, and you might think, is it quite safe or not? Which then maybe means that the clients can't go and do a hydrotherapy, and therefore the hydrotherapist might be annoyed because they've then lost an appointment. Might be the client is annoyed because the hydrotherapist still charges them for the missed appointment. You just end up with annoyed hydrotherapists, annoyed clients. I don't want them to come back to me annoyed. So I kind of give it an extra week just to make sure everything is settled down. So normally 3 weeks after surgery, I'll say they can start doing hydrotherapy. Either that can be on the treadmill, and the treadmill is really nice because it's getting them to walk, and ultimately we do want dogs to walk, and we can do clever things such as adjusting the water level. And if we have the water level kind of say fairly low, around maybe hock level, they'll again cause the dog to almost pick its feet out of the water, so we can get them to almost do Cavaletti pole style exercises in the hydrotherapy pool. Or we can do the swimming as well. So roughly 3 weeks after surgery. And then as we start to progress through, we're going to be again increasing strength, stability, and endurance. So if we wanted to start doing a bit more of our muscle workouts, we can start doing concentric and eccentric exercises. So this is when the leg actually moves. So a bit like us in the gym doing sort of squats, we can get dogs doing sit to stands, where if you repetitively ask them to sit and then stand, that's like us doing our squats. Now, in terms of sitting, if you've seen a dog sit after a TPLO, it'll probably sit like this dog, whereby it's not quite fully flexing its knees and it's got them slightly extended. And this happens once a dog does rupture its ACL, and you maybe heard of it called the sit test. So if you ask a dog to sit and it sits like this, it's potentially ruptured its cranial cruciate ligament. And even after dogs have surgery to treat their cranial cruciate ligament, they will still sit like that, almost kind of regardless of what procedure they have. So it's very common that if the client comes in afterwards and says, oh, the dog still doesn't quite sit normally, that's to be expected. You can get them to sit more squarely, but you need to do a lot of hardcore physio to retrain the dog to engage its muscles, which most people are not going to do, but it is possible to do it. But for most dogs, they will still sit in that more kind of sloppy way. So that's kind of to be expected regardless of the procedure. And in terms of more kind of adventurous exercise, so if you did have a dog that was going to be doing agility, or a working dog that needs to go back to doing high level functioning work, in terms of starting training for that, that's going to be more like sort of say 16 weeks after surgery. So kind of 10 weeks after surgery is usually when I'll say dogs can start to go off lead again. At 6 weeks is when they can maybe go from crate rest to room rest. And then at 10 weeks can go back to normal in the house, jumping on the furniture, running up and downstairs, and start off lead exercise. Again, starting with a relatively small amount, maybe just kind of 5-10 minutes off the lead in a quieter part of the park, and then kind of gradually progressing as the weeks go by. So this is the Dow Jones Industrial Average, and probably not what you thought you would see this evening, but the stock market does act as a very good metaphor for how dogs might recover from a TPLO, whereby when the dog goes home, it should generally be at its worst and have a gradual upward trend as the weeks go by. But it's not always going to be a completely linear increase. There might be times when the dog might seem to be a little bit worse and times a little bit better. And that might be these little dips, might be when the dog maybe jumps from one amount of exercise to another. It might be when the non-steroidals are stopped and they transition off, they might seem to be a bit worse. So there will be perhaps little sort of fluctuations of up and down. So that's okay. And usually we'll maybe suggest, if that happens with the client, we'll suggest maybe just take it easy for a day or two and then try going forward again. What we don't want to see is this happen, which was kind of COVID, and the stock market kind of crashes and drops. So if the dog suddenly really, really deteriorates, that's then a red flag that something is wrong with the recovery. And that's when you need to be, I suppose, sending them back to us if it was us, or back to the surgeon who's done the surgery to look at, so they can see what's happened to try to then rectify the problem. So they should be on a general upward trend. And the key thing is if they suddenly seem to be much, much more lame, that's going to suggest that there's potentially an issue, which in the early stages, we're either going to be thinking infection or mechanical problem with the plate screws or the bone. So the final part was osteoarthritis. And there's only a few slides, so it's not too long, so I won't kind of keep you too late. So in terms of osteoarthritis, see lots of dogs with osteoarthritis, and there's so much that you can talk about and so much you can explain to the client. And it's kind of too much information. So I try to kind of break it down to them into different sections, and I keep kind of dividing things into different sections. So I start off saying that there's generally kind of three options for us that I categorize things into. One of those is surgery, one is medical management, and then the other is kind of a larger holistic approach. And I kind of go through these options. So for surgery, you can either have procedures that try to kind of modify the underlying disease process. So generally, osteoarthritis in dogs is often because there's an underlying problem in the joint. And if you're catching things sort of early enough, sometimes treating that underlying problem can help. So example would be a dog who has degenerative stifle disease because of cranial cruciate ligament disease. Technically, that dog has osteoarthritis there and then when it's diagnosed. And by doing a surgery to stabilize the knee, we're going to potentially slow down the progression of osteoarthritis. Or it might be that we're then doing a salvage surgery if the osteoarthritis has progressed a lot, and trying to modify the underlying disease process is not going to make a big difference. So that's typically either maybe a replacement of a joint, a fusion, arthrodesis of a joint, or potentially amputation of a limb. So again, kind of a disease modifying procedure, you could maybe call it. That's our TPLO. We can do a knee replacement if we have severe osteoarthritis in the knee. So that's kind of a custom rotating hinge knee, or we could consider an amputation. So they would be really the options of surgery. And I'd go through the same thing for the elbow arthritis or hip arthritis and kind of break it down into those categories. In terms of medical management, I'll then kind of run through to them that there's kind of two categories for that. One of them is systemic medications. So that's all of our tablets, and then also intra-articular medications. In terms of doing an intra-articular injection, we don't normally all kind of gown up like this. I was just struggling to find a picture of me having a needle in my hand, but this is kind of part of arthroscopy, so it wouldn't quite be this sterile to do an injection into the joint. And we have then like a range of options that we can offer for intra-articular medications, whether that's something synthetic, like a steroid medication. It might be a medication to help lubricate the joint better, or it might be trying to help the body help itself by using kind of regenerative medicine. It doesn't really regenerate the joint, and kind of reparative or reparative medicine is a better phrase. It's trying to help repair parts of the joint, with sort of stem cells or PRP. And we also then have what I tend to call a kind of a holistic approach. And this is kind of lots and lots of little small things that can potentially all add up to make a bigger difference. So this will be things like adjusting the amount of exercise the dog does, be things like weight management and keeping them lean. It'll be our rehabilitation, physiotherapy, hydrotherapy, potentially supplements, and then kind of modalities in terms of things like laser, acupuncture, ultrasound. These are the little toys that we have as well. And then I suppose kind of during the consults, because it is only a certain amount of time, I'll tend to often focus more perhaps on surgery and medical management, particularly in terms of intra-articular medications. But there is this huge side of things as well. And in terms of your osteoarthritis patients, what I would suggest is to think of it as this big subject with lots of options, and therefore it's kind of too much to fit into a very short consult that you will have with the client. So generally, what I would suggest is to try to have a program or a sequence where you can give them some information, but then get them to come back and kind of go through more information. And it's also a case, and you've probably heard other people say this as well, but it can be a great way to have a team approach to looking after your patients, whereby different members of the veterinary team can do different parts of this. And I suppose what you really want is to have a team captain who's overseeing everything. And as the kind of primary care vet, you're probably the best person to do that, because you'll kind of know that patient more and better. And then maybe what you might do is perhaps you might be suggesting some systemic analgesics for them. It might be you refer to a specialist surgeon to consider surgery. It might be that you can perform, or a referral center can perform, some intra-articular medications. It might be that your nurses run a weight clinic and they'll kind of keep an eye on the dog's weight and perhaps adjust the amount of food they suggest the dog eats. It might be that physiotherapists are performing some of the physiotherapy and hydrotherapists performing some of the hydrotherapy. So I suppose you kind of really want to have a sort of a team approach to these patients, because it's just too much for you as one person to do in that short amount of time that you have. So I suppose from all of our team, we would like for you to hopefully have us as part of your care team to help you help your patients. And thank you very much for coming along this evening. Then do you have any questions? You want to watch them? Yeah. No, so effectively, if you do take the plate out after a TPLO, as long as the bone is healed, the plate's not needed anymore. So the plate's not doing anything other than holding the bone in place. So the question, if anybody's watching this back, was what do you do if you have an infected TPLO and you take the plate and screws out? What happens then? Well, effectively, you have already changed the plateau angle. That's the bit that has done the correction. The plate and screws is just then holding the bone together. So it's fine to take it out, and the dog should still then, if it's recovered from the infection, walk very well like it did prior to having the infection, as long as the infection maybe isn't in the joint and has caused some damage to the articular structures. But it's the same as a fracture. Once that fracture is healed, you can take the implants back out. In veterinary, we do it very rarely because dogs and cats seem to tolerate having them in. In humans, we more often get the implants kind of removed. They seem to aggravate us more. Maybe our dogs can't tell us. Yeah, I wouldn't take a plate out 3 weeks after surgery, but I'll be a bit wary of that. Just worry. It depends on how much healing there is, but you might not get much bone healing after 3 weeks if it's had a TPLO or something in those sorts of lines. Yeah. Moment. Yeah. So in terms of stifle braces, there's been some studies done that have tried to kind of assess how effective they are, whereby they've put the dog in a stifle brace and done effectively walking the dog on a treadmill with a fluoroscopy scope, monitoring the dog's knees. So you can see as the dog is moving, what's happening to the bones. And generally what they've shown is with all the stifle braces, the knee still moves in an abnormal way. So they've generally not been shown to be particularly that effective at immobilizing the joint. They can cause issues with rubbing on the skin and whether patients tolerate them. And maybe what's kind of been shown is that the stifle brace more limits movement in the knee or to the limb, but not in the way we want it to. So it just makes it a bit hard for the dog to walk, but the stifle is still thrusting in the abnormal way. There are always kind of newer variations, and maybe there'll be a newer variation that will help, but yeah, we tend to use them very rarely because they tend not to work particularly well. And I think in a dog so small, it's going to be a bit of a challenge. It's that small. Yeah. Anybody else? Home time. Okay. Thank you, everybody, for coming. Thanks.